Good evening, guys. I hope all of you are doing well. Today we will be uh, having a quick discussion on the guidelines for management of HIV in pregnancy and postpartum period. This is the updated 2025 guidelines. So let's just wait a couple of more minutes for more people to join in, and when we will begin in like 2 or 3 minutes. Fine. Just please give me a thumbs up if all of y'all can hear me clearly and you all can see my slides as well. Okay. Let's begin. So, first of all, good evening, all of y'all, and I'm really glad that all of y'all are here today to learn a little bit about the screening guidelines and management guidelines as well. Now, this guideline is comprehensive. It is almost of it's almost 180 pages, and I've tried to be concise. We will cover what is important for us to know and what is essential for us to know, and then we can once you'll start solving questions for the exam, you will realize that what is the pattern of questions or what are the scenarios that they ask you. Okay. um, we will be going through the session in the form of that we'll begin with screening, then the antenatal period, the labor management, postnatal period, and then in the end a little bit about hepatitis B co-infection. Okay. So if you all at any point have any doubts. Hi guys, good evening. Can you all hear me? I think I got my there was something wrong with my audio. So I was just saying that we will begin today's session with screening, then antenatal care, intrapartum management, and then postpartum and postnatal management. We will be also talking a little bit about hepatitis B co-infection, and all of these guidelines are always in, especially for antenatal care. The antenatal care guideline from NICE would be applicable for all pregnant women, so the ones with the infection as well. Just whatever the points that are extra care for women with HIV will be in this guideline. If you all have any questions, you all can put it in the chat box, and I'll try to answer them to my best possible knowledge. Um, let's begin, and I won't take too long. I think maybe half an hour or so. So I'm not gonna take away a lot of time from Sunday as well. Okay. So first of all, HIV screening. Do we offer all of them? Yes. HIV screening is offered and recommended to every pregnant woman in the United Kingdom. Most commonly, where they usually register with their midwives first, and then they are referred if they're high risk patients. So the midwife is the community midwife would be the first person offering them. Thus, that would be the antenatal clinic, which is run by them. If it is someone who is declining or not wanting it, then that would be something altogether different. We'll discuss about that as well. So most common time for screening would be in the antenatal clinic. And what do we screen for? We screen for HIV, hepatitis B, syphilis. Okay. And apart from the antenatal clinic, however, it can be done at any point in pregnancy. That means if she's come to you late in pregnancy, in labor, or in your maternity triage, anywhere, you can actually go in and ask her for, try to get her screened. The screening rate is pretty good, which is around 99.8%. Now, women who decline, okay, there women who decline from for multiple reasons. There might be someone who doesn't want to get tested because she has a needle phobia. She might decline the other antenatal investigations as well. Or if there could be sometimes, rarely, the woman might know about her screening, her positive status, but maybe her family doesn't know it, or her new partner doesn't know it. We don't know why. There could be many reasons why as to she's declining. So if this happens, then she should be referred to an infectious disease multidisciplinary team. Here, it is essential that they offer her a face to face appointment. That means that you ask the woman to come in and have a conversation around why she is not wanting to go ahead for the screening. Um, Herein we have to always emphasize the points that it is essential not only for her own health, but also for the health of her infant. Um, if she still declines to be tested throughout pregnancy, then what you can do is offer her offer the baby, because once the baby is born, the baby has its own rights, right? So here you can offer HIV antibody testing for the baby, as well as HIV RNA DNA polymerase chain testing, the PCR testing for the baby at birth. Now, this is just the algorithm that is given in the guideline. Let's look at it one by one. One thing that I want you all to note is that there are 2 points. There's one crucial point that needs to be highlighted, is that when a screening test has come negative, that means at that point of time she is negative. Okay. Um, After that, we will basically, she's negative now. That basically means that she does not it is not guaranteed that later on in her pregnancy she could not have the infection if there are high risk factors like new partner or multiple partners that are there in her pregnancy. So that has to be always stated to her that it is right now negative. Usually another thing that is there is that if ever her if a woman is tested positive, then it is essential that you give out the result to her and explain the result to her within 5 days, 5 working days of when the test was conducted. So basically, identify eligible population like pregnant women. You give them the screening information. If she's already someone who is positive for hepatitis B or HIV, then you would contact the screening team, and they will refer to the relevant clinical management. Now, here it is important that you offer and recommend her the screening. This, again, as I said, would be the four asterisks here, basically also mean that it can be done at any point in time. That means in labor, unbooked pregnancies with no records of the screening result. Now, if the screening is accepted for all infections, then what do? You take the sample, laboratory test to report as per the national algorithms. If the result is negative, then the screening team should contact the woman within 10 working days. If it's positive, then inform the woman within 5 working days, as I've told you. And then, obviously, she would be referred appropriately for her further HIV care. Now, for example, here, as I said, she's accepted screening, but not for all infections. You take samples for accepted tests and send to the laboratory to test and report as per national algorithm, and screening team can formally reoffer and recommend the declined tests. If she declines certain, obviously, particular amount of tests, like for example, she doesn't want to do the HIV test again, then that would be something we would sit and call her for a face-to-face appointment and officially reoffer and recommend getting those tests done. Um, Now, here, what basically happens is that when I told you all the concept that she's negative right now, that means she doesn't have any what do you say, high risk behavior of acquisition of HIV during remainder of her pregnancy. Or if one thing that is important is that if a woman does not, or a woman is living with a partner who is HIV positive, then she should be offered repeat testing. Why is that? And especially if the partner does not meet the U is equal to U criteria, which basically means that the partner does not have a good adherence to the HIV care, as well as is not is does not take the prescribed ART. Uh, and if the HIV viral load is less than 200, is not less than 200 copies for last 6 months, and in the at least for 6 months, and in the last 6 months, is basically women who live with a high risk partner as well. Also, it is important that when a woman, you know that someone, she's tested negative in the early on in pregnancy, but she's living with someone, as I told her, who is already uh, tested positive. She has a partner who's tested positive. It is essential that you know the viral status of that partner. Also, PEP should be routinely recommended following condom-less receptive or anal or vaginal sex with an index partner known to be living with HIV, or who has a detectable or an unknown HIV viral load, or who has an unknown HIV status. Okay, so most of the times we would ask about the partner who's living with her. We'd want to know if he is negative, he or she is negative or positive for HIV, and if the person is positive for HIV, we'd want to know the viral load of that person. And if, however, the person is not tested, that is unknown also, then we would think of a PEP. But again, I think they would go ahead for testing. Now, for pre-pregnancy counseling, one important thing that they have highlighted here is folic acid. Now, we know why do we take folic acid. Most of the time, folic acid is recommended before conception and 12 weeks into the pregnancy. uh, Recommended dose for general population is 400 micrograms. For high risk population, that is who takes the 5 milligram dose, is basically if they have a partner with neural tube defect, they have a previous baby with neural tube defect, they or their partner have a family history of NTDs, diabetes, epilepsy, BMI more than 30, and they've had a bariatric surgery. Now, this is a common population. I've taken this from it's basically from the antenatal care guideline, wherein whom do we offer the high dose of folic acid. Now, what the guideline is basically saying that women who are on ART do not there is lack of evidence which basically says that there is any increase in NTDs because the woman is on ART. Correct. So the recommended dose for women who are on ART or women who have HIV is basically 400 micrograms, unless they have any of these additional risk factors. Okay. Vaccinations in women who are HIV, who have HIV. Uh, the inactivated influenza vaccine. Now, this is something that is given to all pregnant women at any stage of pregnancy, especially when the chances of getting the flu is higher. That is the months of October to January when the virus is circulating. Pertussis or whooping cough vaccine, 16 weeks onwards, and ideally by 32 weeks. Respiratory syncytial virus vaccine can also be given from 28 weeks onwards. COVID-19 booster, depending upon the yearly guideline, if it is offered. No live vaccines like MMR, that is measles, mumps, and rubella. Obviously, we know this. If the woman is not what do you say, is not immune to MMR, then we would offer her after delivery at a suitable time. And I think this is something that we all know, that after giving MMR 1 month, we should avoid contraception. We should avoid conception, sorry. So that means we have to offer them contraception. This is another point. Who have an HCV co-infection, you can offer them the HPV, the vaccine against hepatitis B infection. And in women who have HIV and HBV co-infection or HCV co-infection, you can offer them the HAV vaccine as well. Next, we're talking about the sexual health screening. Now, this is common knowledge that having HIV increases your risks of STIs. Okay, that is sexually transmitted infections, including herpes. Now, what is important is to say, what is important here is that having an STI in itself increases your risk of preterm births. Okay. Uh, this and that is why women who are newly diagnosed, especially, or who already are under HIV care, that they should be getting health screening, sexual health screening, as soon as possible, and repeated if there are any ongoing risks in the form of ongoing risk for having STIs. The STI screening should include chlamydia, gonorrhea, syphilis, HBV, and HCV. Repeated annually for those with a change in partner since the last screen. That means if a woman who is under the HIV care and she has had a new partner, then she should have, she should get her the sexual health screening repeated. Now let's move on from the we spoke a little bit about preconception, we spoke about the screening, the vaccines, and now we'll be talking about the antenatal MDT. First of all, the care is always a multidisciplinary team care. All those who have been newly diagnosed or who were not engaged, that means that they have not attended HIV care for more than equal to 12 months, that is a year, should be seen within 2 weeks. This is an important number, that if she's been newly diagnosed or she's not had care for 12 months or more, she should be seen within 2 weeks of the referral being made for the MDT. MDT, that means who should comprise, like what is it comprised of? It's basically comprised of an HIV specialist, that's basically a consultant obstetrician, uh, or a sexual health physician, like someone who specializes in HIV care, an obstetrician, a consultant obstetrician, a specialist midwife, a pediatrician, and there can be a peer support mentor as well. Mental health assessment. This is again like the antenatal care guideline, wherein you should always do a mental health assessment at every visit that you get in the antenatal clinic. And if you find anything that is alarming, you can always make a referral to the perinatal mental health team. For screening mental health, now this is something extra. It's not only related to the HIV guideline, this is from the antenatal care guideline, as to what are the questions that you can ask to diagnose, mental health concerns. So these include, first of all, the woolly questions, which are asked for perinatal depression, or the GAD2 screening, and that's for anxiety. Uh, I'm just going to quickly go over the questions. During the past month, have you often been bothered by feeling down, depressed, or hopeless? Have you been bothered by feeling less interest or pleasure in doing things? And if she answers yes to any of it, is there something you need or want help with right now? These are the woolly questions. And GAD2 is over. Remember, GAD2 stands for 2 weeks. In the past 2 weeks, have you had nervous? Have you felt nervous, anxious, or on edge? And over the last 2 weeks, how often have you been bothered by not being able to stop or control worrying? For this, you have a score of not at all as 0, sometimes, or several days as 1, and more than half days score 2, and nearly every day score 3. If a score of 3 or more is there, then that would need referral to GP and local perinatal mental health services. This is something that's just extra with regard to mental health questions. Now, another thing that I just wanted to add in here is that you all can expect questions from perinatal mental health, because according to the embrace, there are maternal deaths related to mental health, and they are, as you know, they are pretty, the numbers pretty high. I think almost second in number, and it's obviously indirect. If it's due to postnatal depression, it's or postnatal complications, it's a direct cause of death. But if it is irrespective of postnatal, then it is an indirect cause of death for maternal mortality, and thus perinatal mental health is getting a lot of importance now. Mm, Now, this is, I'm sorry, just give me a minute. Now, once a pregnant woman has been diagnosed with having HIV, when do we start HIV? Now, obviously, when someone is detected, you do the viral load, you do the CD4 count. Um, and it should be started as soon as possible. It should be started in the first trimester. This is an important slide. It should be started in the first trimester, especially if the viral load is more than 1 lakh copies per milliliters, or the CD4 count is less than 200 cells per millimeter cubed. Now, however, in the first trimester, we know that there can be significant nausea, vomiting, and that is affecting the ability to adhere to the treatment. Then you can establish by 18 to 20 weeks. All pregnant women, irrespective of their CD4 count, should be started on ART by 24 weeks at the most. What is the first line? They usually give dolutegravir plus emtricitabine tenofovir DX. This is the first choice in the absence of renal or bone concerns. These are the other drugs that they carry that can be considered, like dolutegravir with emtricitabine or tenofovir, dolutegravir with lamivudine, and abacavir. Okay. This is the first line, though, however, which they offer. Now, usually, uh, this is another table for women who are not pregnant but are planning to get pregnant. And this is basically, I wouldn't want to go too much into the detail of this, um, because not really, well, it's not something that might be often asked, but I just need you to be aware that the women who are planning to conceive and who are already under HIV care, there would be a modification so as to have a so as to have a regimen which is compatible with conception. So which can include a preferred anchoring agent like dolutegravir or raltegravir or darunavir, along with a NRTI like tenofovir uh, or abacavir with lamivudine and tenofovir with emtricitabine. That's actually what we're even giving as the first line here. If you see that the first line that we're giving is dolutegravir with emtricitabine, tenofovir. Okay. Um, Usually, in the routine dose alterations during pregnancy are generally not recommended, and this would obviously be something that a specialist would be modifying, and not just anyone, because they generally don't recommend any changes taking place. And if she's on certain drugs that she's on and that requires dose modification, then again, or any dose alteration, then she would be seen by a specialist team to do that. And if there are any concerns, uh, you know if she is already on something that is not a standard regimen, then therapeutic drug monitoring or therapeutic dose monitoring can be done in pregnancy for women who are on such um, regimen. Now, laboratory monitoring. Uh, for women who are under HIV care, who are on ART and they have a suppressed viral load, that means that the copies are less than 50 copies per ml. Then how do you do the viral load testing? This is again an important slide, please. You do the viral load testing every 2 weeks, every 2 months, at 36 weeks and at delivery. Why do we do this? Because at 36 weeks, we would want that one viral load because our plan for delivery would depend on that viral load. And again, we do it during delivery because sometimes, obviously, that might not happen often because if it's less than 50 and she's adherent to her ART, the one at delivery will also be less than 50. But in rare occasion that it's gone up, it's more than 50, then the treatment for the baby might change. Uh, CD4 count should be measured at baseline in the first trimester. Uh, and repeat tests are only indicated if the baseline CD4 count is less than 3350 cells per millimeter cube. So what they're basically saying is that if she is virologically suppressed, that means that her viral copies of RNA are less than 50, then you do one at baseline, that is at first trimester. And if that CD4 count is more than 350, that means it's okay. We don't do the test again unless it's less than 350 and repeat testing is needed. Did you all understand this? Because this is important. Just give me a thumbs up if you have understood the laboratory monitoring part as to when we'll do the CD4 count and when we'll do the viral load. If you'll want me to go over again, we can go over it again if you'll want. Or if you'll have understood, just please give me a thumbs up in the chat box so I know that we can move ahead to the next part. Okay, thank you so much. Um, when do we do repeat testing of CD4? So what they're saying is that CD4 count, if it is more than 350, then a baseline count is done. If it is less than 350, then repeat testing will be done as and when decided by the specialist. They have not specified as to this is the time that they usually repeat. This is for someone whose viral load is suppressed. That means that her that means she has stable virological suppression. That means the RNA copies are less than 50. Starting or switching ART in pregnancy, you commence or you switch. This will depend on the if a woman who is not having ART, she's been diagnosed for the first time and start, or she was diagnosed and was not on ART, or there's a switch in the regimen of ART. When would you do the monitoring for viral load and toxicity, that is TDM? It should be monitored at every 2 weeks after commencing the new ART. Sorry. Just give me a minute. I'll just use the pointer. Yeah. So again at 2 weeks, then monthly until undetectable, and then at least every 2 months and at 36 weeks and at delivery. So here the only difference is if she had a stable viral load, that means she was on ART, her viral load was less than 50, then at we do the testing every 2 months at 36 weeks and then at delivery. Here we are doing it monthly till the viral load becomes suppressed. Once it becomes suppressed, you go for 2 months, 36 weeks delivery. Then you just basically do the algorithm for the suppressed viral load. Resistance testing should be undertaken before the initiation of treatment. Uh, Another thing that they have recommended is who we are initiating on ART in pregnancy, you can do liver function tests as well. And these are women, and this is another, women who present late. For example, they're not present at booking, or they present in at later trimesters. You can give them dolutegravir, emtricitabine, and tenofovir. Um, Alternative regimens are also there. Again, I wouldn't go into the detail. Just remember the first three ones, maybe. Uh, Now, for HIV-2, what they have said is that best is to get an expert opinion because, in general, HIV-2 has a lower chances of transmitting, and care should be monitored as per the expert advice. Again, I'm not going into the too much details of HIV-2 here. Now, this is all about when do we start? If you all remember when I told you all to start, like this important slide in the beginning, when we would do the laboratory monitoring for viral load and for CD4 count. If she does not have a suppressed load, then when we would be testing. And now we will be talking about Management of women who present late in pregnancy and who are not on. mm, this is basically for a woman who presents late in pregnancy. What would you do? This was the same continuation of what we were talking about here, that when she's not booked, and she's someone who comes very late, if she, that is basically after 28 weeks, and she's not on ART. If she's in labor, no. If she's not, then you start as soon as possible the ART, and that ART table we've already seen. This is the table. Okay. If she's, and this would again, then how would the monitoring be here? The monitoring here would be then monthly. Okay, then two monthly, then at 36 weeks and delivery for the viral load. Okay, and here the CD4 count might be lower than 350, so additional tests might be needed. Next, we're talking about if she presents late in late in pregnancy, that is after 28 weeks, and however she's in preterm labor or has had SRM. For both term and preterm labor, you give oral dolutegravir plus emtricitabine and daily thereafter. And here, what is the problem is that if the baby is born to such a mother, then you have to give oral nevirapine, an additional dose of tenofovir, and intravenous zidovudine. That is important. That intravenous zidovudine should be given during the labor. Okay. Now we have a woman. This is also an important algorithm. We have a woman who is untested. Okay, she is untested and presents to you in labor. Then what happens is that first you take the sample, and it is marked as urgent. Maternity service telephone laboratory to relay the relevant clinical information. That means if it's urgent and she is untested and she's in labor, you take the sample, you call up the laboratory services and tell them that there is an issue, that such a the clinically relevant information should basically be passed on. It's usually processed re- uh, re- uh, upon receipt. So that basically means that it will be urgently processed. And if there is, the HIV sample is negative, nothing to worry about. But if it's positive, the clinical laboratory staff verbally informs on call obstetrician and pediatrician of the provisional result. Consider treatment. That means you can consider zidovudine and then this. Okay, if she's positive and she's in labor, then this treatment will come in. Okay. Now, if a woman has to, we've said that she's already on ART or already she's pregnant, have initiated the ART, but you're not getting a viral load that's less than 50. You review the adherence, you see if there's any resistance, do the therapeutic drug monitoring, and optimize the regimen. Now, you remember we do a viral load at 36 weeks. Now, here, if the viral load is still detectable, you again review the adherence, do the resistance testing, add another uh, regimen, add another drug, for example, dolutegravir, if it was not added already. Consider the four drug regimen. This is what is important, that you perform weekly viral load testing after that till delivery. Hmm. Again, if her viral load is detectable at delivery, this is what is very important, is that zidovudine, if latest HIV viral load is more than 1,000, you have to give intravenous infusion. It's basically simple. They basically have this concept that if the woman has a suppressed viral load, how it is managed, and if the viral load is not suppressed, how it is managed. If it's not suppressed, you do the resistance testing, you do the therapy, the TDM if needed. You optimize the regimen, you retest the patient, and especially if it's at 36 weeks, the 36 weeks is come as not suppressed, then you do weekly testing. Okay. Now here what they've said is that for antenatal screening for fetal aneuploidies, best can be NIPT and the combined testing, that is the NT scan with PAPE and beta HCG. Prenatal invasive testing should be obviously if the woman has had a high risk on the NIPT, she would need invasive testing. Then for that you would want her HIV status to be known. If she is positive and the viral load is high, then it should be done only after viral suppression. That basically means that amniocentesis should be deferred until the viral load is less than 50 copies per milliliters. If she is in a breech presentation and she needs ECV, again it should be done when the copies are less than 50 copies per mil. When do we offer ECV? Just additional information for nulliparous, that is primary gravida patients, we would offer it at 36 weeks, and for multiparous patients, we would offer it at 37 weeks. If the woman has any risk factors for preterm birth, she should ideally be referred to a preterm birth prevention clinic. And having HIV infection should be considered as a moderate risk for FGR. Thus, our growth scans and Dopplers would be depend. And obviously, we would have to check her other risk factors for her to fit into the algorithm of FGR screening. Okay, FGR monitoring. Now let's look at what happens when she is coming to us with a rupture of membrane, and she is we have a viral load of at 36 weeks. What we'll do is, first of all, we will be sending, if you remember, at delivery we send one viral load, so that goes in for testing, but the decision is made on the viral load that is the latest, that is usually the 36-week one. Now aim to deliver within 24 hours. If a viral load is suppressed, that is less than 50, you can offer a vaginal delivery. So in such a case, you go for immediate induction of labor or augmentation depending upon her cervical status. If the viral load is between 15 to 399 copies per mils, then here it is the gray zone wherein they recommend a cesarean section, but the decision would obviously depend upon the woman or person who is deciding. There would also depend upon the actual viral load that is there, the trend of the viral load, length of the time that she's on treatment and adherence, and obviously the other obstetric risk factors. If viral load is more than 400 copies per milliliters, then you would go in for a category 2 emergency cesarean section. Um, this I've told you all that if we do it at presentation, but decision is at the latest viral load that's available. Um, Now this is basically for women who have HIV and who have a preterm premature rupture of membrane, that is PPROM. In such a case, again, we would obviously do her viral load when she comes to us or at admission. It has to be an MDT who will do the careful consideration as to what is happening. If it is suppressed, again it's basically we can think of conservative management, but again all of this has to be taken in consideration by the MDT. It usually will be the same between 35 to 37 weeks. We give her the group B streptococcus prophylaxis because we do that for any women with PPROM. Conservative management can be considered for women who have been on the ART, that means who are on treatment for longer than 10 weeks. This is an important point. That is why I have highlighted it, because they can give you a scenario in maybe EMQ wherein you have a woman, she's HIV positive, her viral load is so much, she's been on treatment, and what are the options? One of them could be a conservative management if her clinical assessment can obviously, a clinical assessment can decide, and even a scan and CTG can decide whether her conservative management can be given. It requires multidisciplinary team discussion, regular clinical assessment, and a management plan has to be in place. Here, always remember that if we can pull her on till 37 weeks only if she's taken ERT for longer than 10 weeks. Recent viral load is less than 50 copies for at least and they have to be two most recent viral loads less than 50 copies at least 10 weeks apart. This is a very important point. And if need be, we can give erythromycin as per the preterm guideline. Please make a note of this slide and these, because here it's a little different, because here she has to be on ART and two viral loads 4 weeks apart should be less than 50. If here what they're saying is that if it occurs at less than 35 weeks and the copies are more than 50 copies, then again optimization of the ART should be done. Here MDT again is taking place. So here what would be done, the MDT would decide whether or not when to deliver, what if she can be pulled on till 37 weeks, because most of the here it is not going to be possible, because it says that she has to be on the ART for at least 10 weeks and less than 50, but here her viral load is high. You give her antibiotics for group B streptococcus. Um, mm, then we give her the corticosteroids and the magnesium sulfate or the erythromycin as per the guidelines, as what, however, the guidelines are. We obviously give for less than 35 weeks. Here again for preterm labor, same thing. It's almost the same guideline as the preterm labor guideline. Uh, the only additional point here is that if her viral load is not suppressed, she will be having an optimization of her ART, corticosteroids, group B streptococcus prophylaxis, magnesium sulfate, and tocolysis should be given as per the national guideline. No difference in that. Mode of delivery, this is again very important. Decision regarding the mode of delivery should be done uh, along with after the review of her last viral load, and that would be usually at 36 weeks. We after she's agreed on the mode of delivery, birth plan should be in place. If it's less than 50, we already know this, we can go in for a vaginal delivery. Again, if VBAC less than 50 copies, if it's between, then this is the joint decision as to we take in the consideration the obstetric risk factors, the trajectory, the actual viral load, all of this is considered, and cesarean section after if the viral load is higher than 400. Timing of birth is that usually if the cesarean or the if the viral load is more than 50, to prevent vertical transmission, delivery should be considered from 38 weeks. Okay, the in any other whenever a cesarean section is done for obstetric risk factors, it should be according to that particular risk factor, but only when it's done to prevent the vertical transmission, it should be considered from 38 weeks onwards. Intrapartum management is the same. If it's less than 50 copies, there is minimal evidence that HIV transmission risk and delayed cord clamping if she is uh, only basically it's recommended only if it's less than 50 copies per milliliter. Another thing that is there, that if they do not have any other, and if a viral load is suppressed and she does not have any other high risk factors, she can also opt for a midwifery care during her intrapartum management. Hmm. This I've already told all. This is again an important slide, that when do we give zidovudin intrapartum? Zidovudin infusion is given when women who are admitted for a planned cesarean section and their viral load is more than 1,000 copies. We've already given so for if our guideline says that we offer cesarean section if the viral load is more than 400, right? So here they are saying that they would not be getting zidovudin if her viral load is somewhere at 450. You wouldn't be giving her IV zidovudin. We'd give her when it is more than 1,000. Okay, for a planned cesarean section and infusion. Again, this whole sentence is important, that if it's a planned cesarean and the viral load is more than 1,000, you commence it. It should be commenced 4 hours prior to the cesarean section. If she has a SROM and her viral load is more than 1,000, we would give her the IV zidovudin. Women who present in labor or with SROM who are planning a cesarean section where her viral load is more than 1,000. Infusion should be commenced at presentation but should not delay the cesarean section. So what they're basically saying is that um, women who have come in labor who have an SROM, they basically were put in for a planned cesarean section, but she went into labor before that. You give her the IV zidovudin, but you don't wait for the 4 hours or the time limit. Uh, Initially, if I was not wrong, there was a time limit for it, that if she's had a rupture of membrane within an hour, if you had a cesarean, then that is removed. That's not there. Okay. Untreated people with an unknown viral load who presented untreated or we don't know the viral load, who would, irrespective of the mode of delivery, if she does not have membranes, we would go in for the IV zidovudin. Um, Obviously, women who have more than 50 copies of viral load, the decision whether or not to do the IV iodine can be, it is something you can consider. They are not saying it's recommended, they're recommending it above 1,000, but again, you can consider it if the viral load is more than 50. Now we are almost at the end of our session. We will be now be talking just mainly about the infant prophylaxis and just the hepatitis B. I know this guideline is a little it's very it's a lot of information, but most of the information is relevant because this is the basics that you need to know about taking care of a woman who is HIV positive. So what y'all can do, y'all can actually make notes for this guideline, because I recommend this is because when you write it down, I think y'all will be able to understand it better, because there are a lot of numbers coming in for even the infant prophylaxis. Again, obviously the neonatal team will be knowing about this, but some basics we need to know as well. Now here we have two categories of infants. We have either low risk infants or high risk infants. Low risk infants would usually get 2 weeks of zidovudin monotherapy. Okay. Now for this, it is important that all of these criteria are met. That means she's taking ART for at least 10 weeks, good engagement with maternity, antenatal, and HIV services, at least one viral load measurement in the past 6 weeks prior to delivery. All viral load measurements in the 10 weeks prior to delivery are less than 50, and again, if it's between 50 to 200, it is an individual risk assessment. But what it basically means is that 10 weeks of ART, one viral load at least prior to 6 weeks of her delivery, between 6 weeks to, and like at least before 6 weeks, and all viral load measurements in the 10 weeks prior to delivery is less than 50. Here, then only we would give the monotherapy. Now let's look at this algorithm. We basically ask these questions that, okay, is she 10 weeks on ART, at least one viral load less than 6 weeks prior to delivery, and all viral load measurements for the mother or birthing parent less than 50 in the 10 weeks preceding delivery. Then you say yes, it's low risk. Then delivery day viral load, obviously we'd get it by that, because we do give it at presentation when she comes for admission, and the report would be out. If it's less than 50, you continue the baby to be low risk, you give zidovudin for 2 weeks. If if that viral load comes up to be high and the baby is less than 72 hours old, you escalate it as high risk. That means such a baby whose delivery would come as whose mother's delivery viral load is high, then that baby would be high risk. Now for high risk, obviously, I'm sorry. For high risk, obviously, we would give a multi-drug, that is three-drug postnatal prophylaxis. And that would again be depending upon case to case basis. This is a good algorithm to remember, an easy way to remember those points of 6 weeks, 10 weeks, and all of that. So I think please make a note of this algorithm and revise this, because it basically summarizes the whole PNP. Usually you can give the multi dose that can be given. Here it is written up: 4 weeks of lamivudine or zidovudine and 2 weeks of nevirapine. Here we adjust, if it is low risk, we then only give 2 weeks of zidovudine. Okay, is this clear, guys? I hope you'll have understood this. Now we'll be moving ahead to the immunization part. Herein, immunization is basically for the baby. It's given as routine as possible. Rotavirus is not contraindicated. Only BCG vaccine is different. For BCG vaccine, who are low risk for HIV transmission can receive it at the same time, but who have a HIV transmission high risk, that is, they don't adhere to the criteria that we just discussed here, the all the red ones, then we defer the beta HCG until the PCR testing is completed at 12 weeks of age. Now let's move on to the PCR testing. Now here, what is there? This is basically to check the baby's HIV status. It is done. Now here again, it's divided as two. Okay, it's for high risk and for low risk and not breastfed. So let's look at high risk first. If the high risk is basically it's not fulfilling the criteria of the 10 weeks, the 6 weeks negative, and the viral load less than 50. So here what you do is you do it as soon as birth, at during the first 24 hours, then at discharge. Okay, this is done either by RNA and DNA PCR. Then at 2 weeks, 6 weeks, 12 weeks. Okay, and reconfirmed at 24 months of age by if there is seroconversion. Now here you have to remember that after 12 weeks, then only we can give the BCG vaccine. For infants who are low risk and not breastfed, this is the same. That means till the baby is in the hospital, that is at birth, within 24 hours, and at discharge. Here, instead of 2 weeks, you do it at 4 to 6 weeks. And then basically, why this is at 4 to 6 weeks? Because we give just at 2 weeks of Zidovudin, and then after 2 weeks of cessation of this we do the testing, and then at 10 to 12 weeks, and here again at 24 months. So it's kind of similar, only here additional 2 and 6 is there. Okay, now breastfeeding, most of the times, so basically the guideline recommends that as uh, exclusive formula feeding, that is stop feeding, there is no risk of transmission of HIV. HIV transmission happens through breast milk, but it is limited. Okay, so here what you can do is that they recommend giving the formula feed, but it is again the decision of the mother and the family and the doctors as to what the woman wants to do. Now here, if the woman is the baby is low risk and is going to be breastfed, uh, during the first 24 hours we do as soon as birth, 24 hours prior to hospital discharge, that's the same. Then monthly for the duration of breastfeeding. Following fully informed shared decision making, that's obviously there. As long as viral load monitoring for the mother parent is taking place monthly, the interval between infant testing during breastfeed can be extended to a maximum of 2 months. So basically, we have got two information here. First is that we need to do the viral load testing if the woman is breastfeeding monthly. Okay, that's for the mother. And for the baby, the HIV testing is also done monthly. Now, here what they are saying is that if the woman is adherent to her monthly testing of viral load, that distance can be spaced out to 2 months for the baby for the HIV testing. Okay. Once the breastfeeding is stopped, then you can do it at 4 weeks and 8 weeks after cessation, and again at 24 months of age. Okay, this is very important again because this is something that they usually ask questions on. So I'm just going to highlight this as well. Why would there be an increased risk of transmitting HIV through breastfeeding, especially if the woman were not on ARTs, detectable HIV plasma in the plasma and breast milk, new HIV infection, shorter duration of HRT, um, HIV drug resistance, low maternal CD4 count, longer duration of breastfeeding, if there's an inflammation or infection of the nipple, if there is inflammation or infection of the gut and the mouth of the baby, and mixed feeding. Mixed feeding is bad. Why? Because if you give the formula, there can be some issues with the gut, especially an inflammation of the gut. And if you give the breast milk after that, there is there's increased transmission through the blood. That is why they recommend the formula feeding. Women, those who don't want to feed, those who don't choose breast or chest feeding, then the milk can be suppressed. Lactation suppression can be done by giving cabergoline. Now, this is just postpartum follow-up. Postpartum follow-up review should be done within 4 to 6 weeks. Again, a question. And postnatal baby's infection testing is happening at 6 weeks, so that's there. So this is according to the NICE guideline where you talk to her as to what is the postnatal period, physical and mental well-being, fatigue, nutrition, diet, all of that is the same. But for women who are living with HIV, you need to ask her specific questions like, is she taking the ART? If the ART needs optimization, linkage to HIV care, completion of the infant PEP, because by 4 to 6 weeks, even if the baby is high risk, the PEP would be completed. If there's any issue with the infant feeding and follow up, because even having formula feeding is an economic as well as a social burden. So the woman might need help with that, and completion of partner notification. Now we will be talking about HBV co-infection. That's just last 3 slides and then we'll be done. Basically, what the guideline is saying, that if she's HIV positive and she gets detected with HBV as well, you have to do testings like a second confirmatory HBsAg sample, then do the HBV DNA, HBV E antigen, and E antibody testing. Anti-HAV, anti-H, basically you see if she has immunity. That means you see anti-HAV, anti-HCV, and HDV testing. You do the liver function test, which will include the ALT, AST, bilirubin, albumin, and we can also do uh, testing for INR, that is the clotting test. Hepatic inflammation or fibrosis. Basically, this again, liver fibrosis estimation. Biopsy obviously cannot be done in pregnancy, so we can do the ultrasonography, or the fibroscan can be done. Its fibroscan is no longer contraindicated in pregnancy as the manufacturer guidelines have changed. And LFT should be repeated 2 to 4 weekly. Again, this is not very commonly asked, but this is very specific here, and HBV infection can happen with HIV. That is why I've included this slide in this today's presentation. Um, Next is they have said that the mode of delivery would again be decided as to what her viral load is, but basically just for the prevention of vertical transmission of HBV, uh, they don't recommend doing the cesarean. They should be getting the HBV vaccination, but HBIG has that means the immunoglobulin has certain criteria. And what are these criteria? Uh, that if her HBV DNA is more than 1 into 10 raised to 6 at any point during her pregnancy, she is both HBsAg and HBe, because HBe, if you remember, is having acute, more of an acute infection. HBsAg positive, anti-HBe negative. HBsAg positive, anti-HBe status not known. And if she's HBsAg positive and the neonate is preterm, that means the baby's weight is less than 1.5 kilograms. Okay. Again, a very specific point where they can give hepatitis B immunoglobulin in pregnancy. Okay. So we are at the end of our session. I hope we all we almost took an hour discussing about this, and it's pretty comprehensive, as I could include as much as I can. But what I would suggest is, I think this would be available on YouTube, as because it is a free session. So what you all can do is that you all can go back to it and actually look at it and try to make your own notes. And then when you solve the specific HIV questions, you will have you will be able to answer them better, because in the EMQs they will ask specific questions with related to when we do the testing, what can we offer her, what about the infant prophylaxis, and that is why this guideline is very, very important. It's a must do guideline for your exam. So before we leave and end our session, if you have any questions, you all can put it in the chat box. I'll with regard to the guideline that we just studied. Okay, then I think none of y'all have any questions, so I'll be taking a leave today. I hope you all can revise this going back to the video again. Yes, yeah. For multiple gestations, I can try. I will talk to the backend team, and for twin, I know the nice guideline on twin care is also very multifetal pregnancy is very comprehensive. So yeah, we can give it a try, and I'll let you all know if it is possible. Okay. Yeah, please do go through the video again, and it will help you all answer questions better.